Welcome and thank you for joining us for the joint Transplant Pharmacy and Advanced Practice Providers Community of Practice webinar, Medication Access Explained, Navigating the Road to Approval. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. There is currently a viewership poll displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. The webinar is being recorded and the archive will be available on the TX Pharm and AppCop hubs later this week. Please note that your lines have all been muted so that only the presenters can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A section in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. If there are questions that we do not have time for, we will either answer them individually offline, or we will post the full question with the answer on the hubs following the webinar. Finally, when you log off at the conclusion of today's webinar, you will see a link to a short survey to complete. Please fill out this survey to help us keep our content current and engaging. I will now turn the session over to the moderators to begin our presentation.
Thanks, Anne. I'd like to welcome everyone to today's AST webinar regarding Medication Access Explained, Navigating the Road to Approval. I'm Barrett Crowther, one of the transplant pharmacists at University of Colorado Health, and I'd like to welcome you along with my co-moderator, Cindy Chan from University of California, Irvine, to discuss today's topic. We have a wonderful panel today to lead a panel discussion of a couple cases and give an overview of the complexities surrounding medication access that face our transplant recipients on a routine basis. This is a very, very pertinent topic. As new therapies become available, it's important to ensure that patients have readily available access to these therapies. And today's discussion does a great job of highlighting the intricacies of medication access for our transplant patients. Conflicts of interest are listed as such, and today's discussion does include an off-label use. I'd like to pass it off to my co-moderator, Cindy Chan.
Thank you, Barrett. And with that, I have the pleasure of introducing our panelists today. We have Katie Cunningham from Northwestern Memorial Hospital, Karen Khalil from NYU Langone Health, Danielle Krieger from UCSF Medical Center, Jen McDermott from Spectrum Health, Brenda Muth from the University of Wisconsin, and Margaret Siegfried from the University of Washington Medical Center. So welcome to all our panelists. Next slide. So to start us off is going to be Danielle and Jen, and they're going to discuss with us medical insurance relating to transplant patients and really give us an idea of how this can create challenges in medication access. And with that, I'm going to hand that off to our first speakers.
Hello, everyone. Thank you. So today our objectives are going to be to describe payers and payer mix at the time of transplant, discuss Medicare and immunosuppressant coverage implications, review common medication access barriers and associated outcomes. We'll provide 2 case examples of common medication access issues and discuss further directions, including immunobill and medication access resources. So first we'll start by talking about the payers. It's important to understand who the primary payer and the secondary payers are. A payer is the organization that negotiates or sets rates for healthcare provider services, collects premium payments, processes claims for service, and pays the provider claims. Payers are government-sponsored, like Indian Health Services, Medicare, Medicaid, State Children's Health, or commercial. So first we'll start with Medicaid and Children's Health Insurance Program. They are financed jointly by federal government and state. Medicaid is the federal government matches state Medicaid spending and varies by state. The government matches the state, based on a federal formula and ranges from a minimum of 50 to nearly 75% in the poorest states. Medicaid beneficiaries generally must be residents of the state in which they are receiving Medicaid or be either citizens of the United States or certain qualified non-citizens. If the individual's income is too high to qualify for Medicaid, states have the option to establish a medically needy program for individuals with significant health needs. Children's Health Insurance Program is the program that provides health coverage to uninsured children in families with incomes too high to qualify for Medicaid, but too low to afford private coverage. Commercial plans. These are non-government entities. They include your PPO, your HMO, your point of service plan, their high deductible health plans, their private fee for service. It's important to note that over 2/3 of Medicaid beneficiaries are also enrolled in private managed care plans that contract with states to provide comprehensive services. Private insurance may assume a cost of an organ transplant. However, there is usually a maximum or a cap on the amount that the company will pay. Medicare. Medicare is a federally funded payer. You must be a United States citizen. You can be over 65 years old to be eligible. Patients who receive disability benefits for 2+ years are also eligible for Medicare. Medicare based on end-stage renal disease. Individuals are eligible for Premium Part A if they receive regular dialysis treatments or a kidney transplant. They have filed for an application for Medicare and meet one of those criteria as noted. Medicare enrollments for patients with end-stage renal disease is unique. It's important to also know that patients must sign up. Enrollment is not automatic. And previously, enrollment was terminated 3 years after kidney transplant, prior to the Immunobill, which will be discussed later in this presentation. Next slide. Insurance at the time of transplant. As this table demonstrates, we looked at the data from the 2019 OPTN SRTR report. Medicare was the most common payer for kidney transplant, as expected. Most commonly seen, 30 to 50%, is private and Medicare insurance across all transplant types. We will note that intestine includes pediatrics, therefore, Medicaid at the time of transplant is more common. For simplicity, combined intestine and liver are not reported. Next slide. Medicare In Depth. So Part A. Part A is your hospital insurance. It covers your inpatient hospital stay, skilled nursing facility care, hospice, and some home health care. Part B is your medical insurance. It covers provider services, outpatient care, medical supplies, and preventative services, and some drugs. Usually Part B covers drugs you would not usually give to yourself, like the ones that you would get in your provider's office or hospital outpatient settings. Some examples I'll go through. The caveat is that these drugs need to be reasonable, necessary, and appropriate. Medicare covers transplant drug therapy if Medicare help pay for your organ transplant. Covers DME like an infusion pump if the drug is reasonable and necessary. They'll cover erythropoiesis stimulating agents if you have end-stage renal disease, or if the drug is used to treat anemia related to certain conditions. Drugs that we use like IVIG provided in home are paid for by Medicare if and only if you have a diagnosis of primary immune deficiency disease and it's medically appropriate to be given at home. So Part B will cover the IVIG, but it doesn't pay for other items and services that are related to you getting the IVIG at home or to our patients getting IVIG at home. Part C. Part C is your Medicare Advantage. It's a private insurance alternative to original Medicare. Most Medicare Advantage plans include a prescription drug coverage, Part D, which we'll continue to discuss. Patients can join a separate Medicare prescription drug plan, the Part D, that can't afford drug coverage like the ones covered in Medicare Advantage. It's important to mention Medigap at this point. Medigap is a supplement, it's a Medicare supplement insurance policy. It's an optional supplement to Medicare A and B. The Medigap policy cannot be used to pay your Medicare Advantage copayments, deductibles, and premiums. It may be to your patient's advantage to join a Medicare drug plan because most Medigap drug coverage is not credible. Now for Part D. Part D covers transplant drugs that Part B doesn't cover. All plans cover a wide range of prescription drugs that patients with Medicare take, including most drugs in certain protected classes, like our immunosuppressants. The concern is that, is the drug on the plan's formulary? And is the medication on a tier that's financially possible? For example, a drug in a lower tier will generally cost you less than a drug in a higher tier. Next slide. Next. Thank you. So immunosuppressant drug coverage through Medicare. It's important for both the transplant team and the recipient to understand whether Part B or D is the correct payer for their medications to ensure proper billing and payment. So if a transplant recipient has Medicare at the time of transplant, and if Medicare pays for the transplant at a Medicare validated facility, his or her immunosuppressant drugs are covered under Medicare Part B. They must have Part A at the time of the transplant and must have Part B at the time to get their medications. The cost to patients is that they pay 20% of the Medicare approved amount for the drug, and the Part B deductible applies. Medicare drug coverage under Part D covers immunosuppressive drugs if Part B doesn't cover them. You'll see later in a case presentation, if a transplant recipient has any other insurance at the time of transplant, like Medicaid or private insurance, then later becomes eligible for Medicare, i.e. they turn 65, his or her immunosuppressant drugs are covered under Part D. I think a take home is Medicare covers drug therapy if Medicare helped pay for your organ transplant, but there's a lot more caveats. So now I would like to hand this over to Jen to discuss further access barriers.
Thank you, Danielle. Medication access barriers frequently encountered can include loss of insurance or change in insurance plan that can impact prescription medication coverage. Payer drug utilization management, including medication prior authorizations or PAs, which is a management process used by insurance companies to determine if a prescribed product or service will be covered. These frequently can result in delays and ultimately impact medication adherence. Finally, some insurance plans mandate that only certain mail order pharmacies be utilized. This can create further delays and add complexity for patients in obtaining necessary medications. Next slide. A patient with kidney disease has their dialysis treatments paid 100% by Medicare, and Medicare will also pay for a kidney transplant. However, until recently with the immuno bill passing, these kidney transplant recipients only received immunosuppressive drug coverage for 3 years after transplant. If a recipient did not have an alternative health insurance or did not otherwise qualify for Medicare, they lost their medication coverage. This study by Hart and colleagues determined the association between timing of Medicare loss, immunosuppressive medication fills, and kidney allograft loss. And the hazard for allograft loss was 990 to 1,630% higher after early Medicare loss, and 140 to 740% higher after late Medicare loss, demonstrating ongoing Medicare access before and after 3 years post-transplant can impact graft survival. Next slide. PAs are usually required for most transplant-related medications, including immunosuppressants and anti-infectives. The PA process, unfortunately, as many of us are acutely aware, can be lengthy, frustrating, and difficult to navigate, frequently overwhelming clinic staff, providers, and patients. According to one report by Cover My Meds during the PA process, as many as 37% of prescriptions initially rejected at the pharmacy are never picked up by patients. According to the 2019 American Medical Association Prior Authorization Physician Survey, 91% of patients experience some delay in receiving care due to lengthy PA procedures, with 24% of physicians reporting that PAs have resulted in patient adverse events and 16% reporting they have led to patient hospitalization because of delays. PAs are commonly denied due to incomplete information, so it's paramount to have standard work within a clinic to ensure all required information is submitted and reviewed, and request is urgent for life-sustaining immunosuppressants. Common reasons for PAs include high-cost medications or high-tier, brand name medications, step therapy requirements for where first choice drugs, also known as frontline or first step drugs, such as generics and lower cost options, may be required to be tried first before the insurer will cover the more expensive drug. Quantity and dosage limits, non-formulary requests, and finally, coordination of benefits, such as Medicare Part B versus D determination. And this is often the case with immunosuppressant drugs. Next slide. Importantly, when examining Medicare Part D plans, PA requirements have increased from 8% in 2007 to approximately 24% of covered drugs in 2019. Not only are PA requirements increasing, but a disturbing trend has been noted among Medicare Part D plans denying immunosuppressant drugs for off-label use not supported by CMS-approved Compendia, which Katie will be touching on in more detail. A multi-center case series was recently published by Lucian and colleagues in American Journal of Transplantation demonstrating 66 immunosuppressant denials, most commonly mycophenolate mofetil in lung transplant recipients. And this included 39 solid organ transplant recipients overall. Of note, the denials were unfortunately frequently upheld despite varying levels of appeal, with 74% of first level appeals, 96% of second level appeals, and all of those reviewed by an administrative law judge were upheld. Next slide.
Thank you, Danielle and Jen. You really highlighted the complexities of navigating insurance. And to demonstrate this further, we have our first patient case, and to present that to us, it'll be Margaret and Katie.
Thank you so much. I'm Margaret, and I'm going to present a case that demonstrates a solid organ transplant for a non-kidney recipient who was transplanted with commercial insurance. JC is a 62-year-old male who underwent a bilateral lung transplant secondary to COPD. Discharge immunosuppression included tacrolimus, mycophenolate mofetil, and prednisone. Insurance at the time of transplant was a commercial payer through the patient's employer. Medications were covered with a $15 copay. Next slide. When JC turned 65, the patient became eligible for Medicare. Part D plan was selected that listed immunosuppression medication as on formulary. JC submitted for medication refills as usual. The transplant clinic received notifications that the prior authorizations would be required for tacrolimus and mycophenolate mofetil. The insurer faxed a denial letter for mycophenolate mofetil due to lack of FDA approval for lung transplant. mycophenolate mofetil is not listed as an indication in one of the 2 approved compendia. Next slide.
Thanks, Margaret. So this is going to kind of walk through this path of JC. So we know that JC was not 65 when he underwent his lung transplant, and he had that commercial insurance at the time of transplant. So then he turned 65 and he is eligible then for Medicare. And the patient selects a plan that mentions or notes that all immunosuppressive agents are on formulary. What we see then is that the prior authorization is required for his medications with this new Part D plan. So his tacrolimus and mycophenolate required prior auths. The tacrolimus was approved, however, the mycophenolate was denied. So options then, there are options for people to appeal these prior auths, as we saw that Jen was presenting. So the first level appeal again was denied, and the second level appeal again was denied. And as Jen had spoke to, all of these appeals from this multi-center case series that went up to a Medicare administrative law judge were denied as well. And this was the same case for JC. And even though the judge in the article that was published in AJT, it sounded like they expressed empathy and really understood that these drugs are needed and for his, to prevent rejection, they felt that they had to uphold the ruling based on the verbiage in the Medicare prescription drug benefit manual. So frustrating from everybody, I think, along this whole path here. So then what happens for our patients and for all of us? So we can look for ways to obtain the medication by an alternative method. The patient, potentially could pay out of pocket if they're in the financial situation in which to do so. We could potentially seek out using GoodRx coupons to try to decrease the cost for that specific medication. And then we can try to enroll patients in a patient assistance program. And this is really always worth a shot. Even if you don't think your patient meets criteria for enrollment, we've been surprised at which then they do become approved for, patient assistance. And lastly, which is the least desirable option, especially for a lung transplant patient who needs to be maintained for the most part on our first line therapy, which will include an antimetabolites. But the other consideration would be to switch to an alternative immunosuppressive regimen. But again, this is not ideal, at least in this type of situation. Next slide. So kind of looking at a closer look of the Medicare Part D. So we know that the Medicare Prescription Drug Benefit Manual mandates that Part D plan sponsors include all of our immunosuppression. So for a patient, when they're navigating this and navigating what type of plan to select, if they see that their current medications are listed on the formulary, then naturally they're going to think that they are going to be covered. But this is exactly what it doesn't mean. It doesn't mean that this is going to be covered for an individual beneficiary, because then Medicare, the Part D plan mandates that these drugs have to be used for a medically accepted indication. So this either means that they have to be FDA approved for that organ transplant type, or that indication is supported by one of the compendia. And this is either Micromedics or the AHFS Drug Information Compendia. And so if these medications are used outside of these parameters, then they can be vulnerable to denial. And so what we use as standard of care in first line for many of our organ transplant recipients are thus subject to this denial. Next slide, please. So this table is going to show you the different types of organs. At the top, you can see, and then on the left-hand side going down are all of our immunosuppressive agents that we tend to use for our various organ transplant recipients. Any red box that you see there indicates that that medication for that particular organ is thus subject to denial by Medicare. So you can see, looking at our kidney transplant recipients, we have FDA approval for all of our immunosuppressive agents with the exception of leflunomide. However, that is actually approved based on the compendia that Medicare also has. So we don't run into these problems with our kidneys as much. And as you can see, as we move over to the right with our organs, we see liver, where there's more approved uses. But as you move on, and in the case of our patient JC, you can see that only our calcineurin inhibitors, tacrolimus and cyclosporin, as well as leflunomide, which isn't something we tend to use much in lung transplant recipients, carry either this approval from the Compendia. So, navigating these denials kind of takes us back then to the end of our roadmap, where we have to explore these various options to get these drugs covered and provided to our patients. From my experience, and you can see it's not just lung, it affects pancreas, heart, intestinal transplant as well. And in the case series in AJT, they really, looked at various denials across all organ types. But based on our experience, we have had pretty good success in enrolling our patients in patient assistance programs, but clearly this can be an extremely frustrating situation and confusing for our patients and our providers navigating this process. Next slide.
Thank you, Margaret and Katie. I think you really demonstrated how even our commonly used medications can be difficult to obtain. We now move on to our patient case number 2. We have Brenda and Karen who will be presenting it, and they're going to take us through the process of starting Belatacept on a patient.
Thank you, Cindy. Today we're going to discuss a patient's transition from calcineurin inhibitor to Belatacept. TM is a 68-year-old male with bipolar disorder and end-stage kidney disease due to lithium toxicity and type 2 diabetes. He receives a DCD, deceased donor kidney transplant, with a high KDPI. He has a negative virtual cross match and his PRA is 0. He is EBV positive and his donor is EBV positive. TM receives alemtuzumab induction with early steroid withdrawal. And the plan for him is, because of his bipolar disorder, to keep him off of steroids to prevent problems with mania. He is on 2 antipsychotics at the time of transplant, and he remains on those medications post-transplant as well. He weans off of steroids on post-op day 5. His maintenance immunosuppression is tacrolimus with a goal level of 8 to 10 and mycophenolate sodium 720 milligrams twice daily. His insurance is Medicare A, Medicare B, as well as a commercial insurance. His post-transplant course is complicated by delayed graft function. He requires 2 weeks of dialysis. He does have a nadir creatinine of 2.8 milligrams per deciliter with an estimated GFR of 28 milliliters per minute. He has a biopsy which demonstrates acute tubular injury, no evidence of rejection. He also develops hallucinations and mania and requires transfer to inpatient psychiatric service on post-op day 14. His antipsychotic medications are adjusted. He's also noted to have a small wound dehiscence. Ultimately, he is stabilized and he is discharged home. He is unfortunately readmitted 2 days later with non-adherence, with mania, and he's not safe to be at home. The transplant team has multiple discussions regarding how to best manage what appears to be a neurotoxic effect of tacrolimus and discuss conversion to Belatacept. He is not a candidate for an mTOR inhibitor because of his small wound dehiscence. He is ultimately converted to Belatacept with the de novo induction protocol, and his tacrolimus is stopped. He remains off of steroids. In general, we try to do Belatacept conversion in the outpatient world because of billing and cost, but it was unclear when TM would be safe for discharge. So he received his Belatacept as an inpatient, and the cost of this comes out of the DRG. Next slide. So considerations for transitioning a patient from calcineurin inhibitor to Belatacept include calcineurin inhibitor related neurotoxicities, improvement in GFR in the setting of CNI nephrotoxicity, understanding that there is a risk for early acute rejection in patients that are not kept on CNI. Also, thrombotic microangiopathy might be a reason for transitioning, and patients that are at risk of non-adherence may be good candidates for Belatacept as well. Next slide. This is the roadmap to TM's Belatacept administration. First, the provider requests the Belatacept, and then the provider and the pharmacy both verify that the patient is EBV positive. Our inpatient pharmacist then submitted our inpatient pharmacist did determine that the patient's insurance would cover Belatacept and enrolled TM in the Nulogix distribution program to obtain a patient-specific PIN number. Our transplant coordinators do this for the outpatient world, and our transplant pharmacists do that on the inpatient side. Nulogix then assigns the patient-specific PIN number, and this takes about 1 to 2 days to obtain. The pharmacy purchasing department then orders the Belatacept using that PIN number. Our institution does have a supply of Belatacept on site because we do use a lot of Belatacept, so we can use a dose that's on site and then replace that dose when we receive the specific dose that was ordered for TM. TM then does receive his first dose of Belatacept in the hospital. And our case manager determines where TM will receive his outpatient future infusions. Since he lives close to the transplant center, he does continue to receive his infusions as an outpatient in the transplant clinic. Now, Karen will tell you more specifics about accessing Belatacept for patients.
Thank you, Brenda. So given the complexity of the process for obtaining Nulogix or Belatacept, Bristol Myers Squibb or BMS can actually offer support for various aspects of this process. If you don't have resources for a team member to actually conduct a benefits review, they can do it for you. And generally the turnaround is about 24 hours or so. And as mentioned before, since Belatacept is only FDA approved for use in kidney transplant recipients, it often requires a prior authorization for all the other organ groups. And this is something that the BMS Access support can help you with as well. If the prior authorization is denied by the insurance company and it goes into appeals, they can offer appeals assistance as well. For patients with high copay, BMS can actually offer those eligible patients assistance to pay as little as $50 per infusion. But for patients without any prescription drug insurance or those who are underinsured, the BMS Access support can actually make referrals to independent charitable foundations that may be able to help. The Bristol Myers Squibb Patient Assistance Foundation is actually a charitable organization that can provide medication free of charge to those eligible, usually those who are uninsured or have established financial hardship. Next slide. To sum up the process for navigating access to Belatacept or Nulogix, as mentioned before, your team must obtain coverage for both drug and infusion services. And as mentioned, because it's only approved for kidney transplant recipients, it may be more challenging for other organ groups. And honestly, the duration of this process will vary quite drastically. From my experience, it can take anywhere from 5 to 7 days or up to several weeks. And as Brenda mentioned, some hospitals may have the medication on consignment, so they are able to start therapy as soon as patients are enrolled in the distribution program, while others will need to wait for that patient-specific identification number in order to order patient-specific medication and wait for that to be delivered for administration. Of course, this can potentially delay the start of care for many patients. And oftentimes it can actually lead to short-term admissions for drug administration inpatient if the medication is approved, but the patient has not been able to be set up for outpatient infusion yet. As alluded to, it takes numerous people from various disciplines to manage patients' Belatacept infusions. From transplant and community providers who need to actually enter the orders for the medication to the infusion center, follow up on compliance and weight changes, which obviously can be quite challenging if they manage a large practice, to pharmacists who help confirm eligibility clinically and assist for the process of approval and ordering of medication, to care managers and coordinators that help facilitate the benefits investigation and financial clearance, approval, and setup of those infusions. And this can be especially challenging in areas where there are limited local infusion centers that are actually willing to administer Belatacept. Home infusion may be an option, but may be difficult to obtain depending on the patient's insurance, especially given the limitations with Medicare Part B. Next slide. So here I have listed the Belatacept or Nulogix medication copay by insurance type. For commercial insurance, patients will pay as little as $50 per infusion. For Medicare patients, depending on their dosing, whether it's the initial de novo dosing or maintenance, they'll pay anywhere from $0 to $750 approximately per infusion for the initial de novo dosing. And then once they're on their maintenance infusions, it'll be anywhere from $0 to about $380 per dose, and that's dosed monthly. If patients have supplemental coverage or Medigap with their Medicare Part B, this can help offset that 20% difference that patients are responsible for. For Medicaid patients, the infusions will range anywhere from $0 to $20 each. And of note, this only addresses the cost of the drug and not the infusion services. So as I mentioned before, the BMS Kidney Transplant Copay Assistance Program will provide financial assistance for out-of-pocket deductibles, copay or coinsurance costs for those who are eligible, only those who are commercially insured. However, patients who are insured through federal healthcare programs are not eligible for copay assistance, but the BMS Access Support can make referrals to those independent charitable organizations I mentioned to offer support for those specific patients. Next slide.
Thank you, Brenda and Karen. Lastly, we have here a discussion and conclusion, which we're going to bring back Jen, and she's going to give us some concluding remarks and future directions.
Thanks, Cindy. There are several medication access resources that can fill the gap due to barriers. GoodRx offers reduced pricing on medications not using insurance on select medications only at specific pharmacies, and an online application for this is available. Of note, GoodRx does collect data from users, but users can opt out from any cookies and tracking within the web page. Pharmaceutical manufacturers may offer various programs, including free 30-day trials as a bridge, copay cards, which are limited to commercial payers, and prescription assistance programs. There are also state-specific medication assistance programs, and this can include drug savings cards that are offered by many states free for everyone and do not have restrictions. And these typically offer some discount on copayments. There are also transplant-specific state medication assistance programs in about half of states that are more income-based and have certain criteria. Foundation support includes foundations such as HealthWell, American Kidney Fund, and American Transplant Foundation, as well as Good Days and PAN Foundation for hepatitis C related treatments. And the AST Transplant Pharmacy COP, also our medication access work group has created resource documents both on medication access as well as limited distribution drugs, including Belatacept. And these are now housed on the AST website, although currently you must be a member of the pharmacy COP to access these. However, if anyone is interested and cannot navigate this, I'm happy to share these. Next slide. So in conclusion, understanding payer and associated coverage is complicated and not intuitive, but is essential. Provider and patient understanding is important to navigate medication access barriers to prevent delays in obtaining necessary life-sustaining medications. Immunosuppressants billed through Medicare Part D may be denied if off-label or off-compendia use, and appeals are often rejected. And limited distribution drugs, including Belatacept, have additional hurdles that require process knowledge. Next slide. So where do we go from here? Future directions include having dedicated staff within a transplant program for prior authorizations, medication assistance program applications, Belatacept enrollment, and infusion coordination, as well as adherence tracking. And obviously we know with clinical workload, this is difficult for one discipline to manage. So it's likely a multidisciplinary approach is best, involving medical assistants, pharmacists, pharmacy techs, providers, financial coordinators, social workers. Medicare and insurance industry lobbying and reform, of course, needs to be continued. And CMS is exploring regulatory changes to PA workload through its Patients Over Paperwork initiative. In January of 2018, organizations representing physicians, pharmacists, hospitals, and health plans signed a consensus statement agreeing to strategies for improving the PA process and reducing needless administrative work. Unfortunately, the recommendations of this initiative have not been substantially implemented by all health plans. As we know, there's currently a critical flaw in the construct of the Medicare prescription drug manual regarding immunosuppressant coverage for organ transplant recipients. In fact, it's dangerous that Medicare Part D plans are allowed and encouraged to rely solely on select drug compendia when making coverage determinations. And unfortunately, this reference compendia are not up to date and do not reflect current best practices in organ transplantation. AST has recommended to file requests for review of each affected immunosuppressant drug within the CMS approved compendia in hopes they will revise their list of appropriate off-label uses to include those deemed clinically appropriate by the transplant community. There has been a request filed with DrugDex in April of 2019, and unfortunately, there's no response that I'm aware of that's been received to date. Another option is to expand the definition of medically accepted indication for immunosuppressant drugs and organ transplantation, similar to what's already been done for anti-cancer chemotherapeutic regimens. This would allow for consideration of peer-reviewed medical literature, as well as Part D sponsors would be required to utilize broader Part B recognized compendia, which includes Lexicomp, when considering off-label use. And the advantage of this is Lexicomp carries off-label indications for some things not covered by the other compendia, including mycophenolate mofetil, sirolimus, and azathioprine for heart and lung transplant. Of course, education for providers and patients, as well as ongoing financial review standards within a transplant program for patients is important to continue to assess coverage and barriers. Finally, for the past 20 years, the AST has been advocating and working for passage of the Immuno Bill to provide access to immunosuppressants for life in kidney transplant recipients. And finally, this legislation has become law and begins in 2023. Kidney transplant patients may enroll beginning 36 months after transplant if they have no other health insurance and are otherwise ineligible for Medicare. This still has an associated cost, as enrollees will pay a monthly premium equal to 35% of the standard immunosuppressive drug costs, expected to be about $243 in the first year of the program and increase gradually. An analysis by the Department of Health and Human Services estimates that the Immuno Bill will prevent approximately 375 allograft failures annually, and also is estimated to save American taxpayers approximately $400 million. So it really is a win-win. And that concludes our presentation for today. And now we're going to open it up for any questions.
Awesome, thanks, Jen. I'd like to extend a thank you to all our presenters today. I'm going to actually stop sharing our slides and invite our presenters to share via video for hopefully a good discussion post-presentation. I think we have several questions coming in. Feel free to add questions to the Q&A link at the bottom. I really do think our presenters did a wonderful job highlighting the complexities post-transplant that our transplant recipients face. I think for many of us as transplant specialists, it is complex and confusing and doesn't always make the most sense, but especially putting yourself in the patient's shoes is especially important. So I think being able to provide those resources to our recipients and pre-transplant patients is absolutely essential. I think this was even further highlighted during the pandemic that added just additional barriers to accessing necessary medications. So with that, I think we'll transition to questions. Did you want to kick it off, Cindy?
Sure. Yeah, the first one, this is a great question. I think I'm probably going to direct this to Jen or Danielle first. It says here, can a young adult patient who lost their Medicare 3 years post-transplant get it back under the new Immuno Bill?
Yes, they should be able to. The Immuno Bill will go into effect in 2023, but if they otherwise are eligible, yes.
They have to apply for it.
And there will be an enrollment period. So that's an important point as well.
I think our next question revolves around pre-approvals for especially expensive medications such as de novo Belatacept at the time of transplant or Hep C treatment. So I'll first direct it at Katie, but if anyone has had success at this process, I would love to personally hear as well.
I can't speak to de novo Bella because we've never done that, but we do a considerable amount of Hep C, donor positive to recipient negative. And we came up with a standardized process that involved our hepatology colleagues and infectious diseases and our specialty pharmacy. And essentially what we do is we order labs on post-op day 5, and we generally have to wait to get the genotype back. Although we've recently had more success in getting the Hep C medications approved without even having the genotype because we're using the pan-genotypic agents. And so we've been able to get insurance approval. So we then send a prescription to our specialty pharmacy, and we have a Hep C pharmacist who does that along with us. And then they will order the drug in, and then they will get it shipped to the patient depending on where they are. This can get very tricky if the patient goes to rehab, but I won't get into all that. But then as soon as the drug is in the patient's hands, we then counsel them, and kind of then they will follow up with the respective people to for follow-up. But we've gotten close to like 30 days, but never really beyond that.
Okay,
Awesome.
thank you. I have another question here in the chat, and I think it's an advocacy question, and it's describing the situation of where the patient has private insurance requiring a mail order pharmacy for the first fill. How can we, and this can cause problems because the medication may not arrive in time for discharge. So the question is, what recommendations does the panel have, and what can we do as providers to change these insurance practices?
Okay, Jen, go ahead.
Well, with some payers, sometimes you can request an exception for the first fill. We've had some various success with getting an override for the first fill to enhance medication teaching and not prevent delays. And then if that's not successful, then we follow the rules that are set forth and obtain it from the mail order and arrange for delivery to our clinic space. I think there's obviously a lot of work to do with insurance reform and working with the Med Access Work Group as well as public policy to try to target these issues and with payers.
I think
I would also
that-
venture to say, if possible, some transplant centers will give a 1-week supply of important medications to the patient, and or we can try to get, if you have a pharmacy that's affiliated with your institution, you can just pay for the 1 week, usually on a reduced price. And then patients will at least get the 1 week to take home with them of the most important medications until you can get them sent to the clinic. That's another bridge as well.
That's what we do, actually. We'll voucher them. And then we try to send all our prescriptions on post-op day 0 down to our pharmacy in the hospital so that we are acutely aware of any issues. And then we will try to call, as soon as possible with the patient. The barriers are often that the patient has to set up the account themselves, and you can't always do that on behalf of them, and get, payment on file. And so it can take a long time, but we've been fortunate enough to be able to vouch for a week and bridge them until they get their supply mailed.
Our next question comes in the chat. It's really to the group, whoever has had experience or experience navigating really individuals who need to sign up for Medicare after transplant because now they are eligible for Medicare due to the transplant event and mandated to pick it up due to Medicaid or private insurance requirements. And the information they may provide.
So I think for kidney, it's easy because they just fill out the 2728 form. I defer to my other panel colleagues to talk about other organ types.
Yeah, I think this becomes kind of at least on the kidney side, a coordination issue at times to ensure that they're dual eligible for both Medicaid and Medicare, because not always do Medicare and Medicaid speak perfectly well in unison. So ensuring that the pharmacy is able to bill medications correctly, so those copays are affordable and not necessarily astronomical as I've seen in the past.
I would say that our social workers help a lot with this. So I don't have as much experience with it, but
Also, coordinators within the program are helpful as well.
Great, thank you. And from the same person that asked that question, we have a second one that says, how do you recommend pharmacists or transplant team members to become more knowledgeable about the Medicare process? Hopefully this webinar answered some of those questions.
I mean, personally, I've learned a lot from our social workers. They have done we've asked them to do some talks for us or for, our transplant nurse coordinators to kind of teach us from their perspective. And it's been incredibly helpful. I've learned a lot from Jen in this process. So, other, colleagues, but I think at your institution, if your social workers are involved, they can be a phenomenal resource.
I think also having your pharmacists that actually work at the pharmacy, not your transplant pharmacists that are working at your specialty pharmacy, they can come give talks and lectures because they're the ones who are doing a lot of the billing. They're much more understanding of what to do than our community pharmacists to dispense the medications to some of our transplant patients.
Yeah, definitely echo that. I think it's challenging too when transplant recipients are referred to insurance brokers that may not necessarily have as much experience in transplantation. So having set insurance brokers who have that experience is very valuable for a transplant center to really help individuals navigate that process, and really taking an active role as a transplant center with all personnel to discuss insurance options, et cetera. Of course, you can't really say exactly which plan fits an individual the best, but really provide those options is essential.
I think also note utilizing your pharmacy benefits, your drug company benefits, your copay cards, any type of program like that is really helpful to get things moving forward while you're figuring out the proper way to go through the insurance.
I think also just asking questions when things are denied. Why is this denied? How is it being billed? Just to gauge a better understanding of that, because sometimes it's not being billed right. And I think as you over time, talk to various specialty pharmacies, payers, I know that's how I've learned a lot along the way of the rules, and because it's not easy to understand, unfortunately.
Yeah, I think it's having those key personnel that you highlighted, Jen, at the individual transplant center, because it really does take a lot of time and energy, especially when it's like a specialty pharmacy mandate, trying to reach out to these mandated specialty pharmacies to ensure that they're billing medications correctly, because it's not uncommon that they are billed incorrectly, so ensure that the patient gets the correct medication, or like trial cards are applied is a huge issue too.
And educating your patients is super important so that they don't pay $1,000 copay if they don't have to. So if you can educate them, then they can go back to their pharmacist and say, I don't think it's being billed correctly. They may not understand what that means, but then that will take the next step where they'll contact the transplant center.
Okay, Barrett, should we open it up to some moderator questions?
Sounds great. Let's do it. Feel free to keep adding Q&A questions if anyone in the audience has questions.
Okay, I'll go with the first one. So to our first group, Jen and Danielle, what state or county assistance programs are available for low-income transplant recipients?
So I can take that one. We actually have collated the state programs because there are various programs, and we do have that on the AST Med Access resource page. I know in Michigan, we have Second Chance at Life, for example. I know in Georgia has medication access programs. So there's various state-specific programs, and happy to share those.
So I think another issue that we sometimes face, at least here at University of Colorado, is our individuals with out-of-state Medicaid. And so I was really wondering if others have had issues with medication billing for patients with various out-of-state Medicaid programs. So I think I'll first send this to Katie.
Thanks. Yeah, recently we've had a couple of those situations pop up with our COVID lung transplant patients who are being transferred to us from all over the country where they had Medicaid in their respective state. And so what we've had to do is essentially have the state ship us the medications. And so we cannot fill from our pharmacy. And so we have, and that of course is going to delay discharge and everything, but we'll have them shipped to us. And then either if the patient, we require the patients to live here in Chicago after lung transplant. So even to either to their residence or to us, but then they have to bring them into the clinic essentially. And then we make sure that they have everything and everything is good to go. But it is a very difficult, time consuming, especially dealing with, pharmacies that we're not used to dealing with and aren't used to, filling medications for our transplant patients. So that's one thing we've done. I'm not sure about anybody else.
Katie, is this particular to COVID lung per se, or have you had this experience prior to your COVID lungs?
I haven't, just because everyone, else is generally regional around here that gets transplanted. So these are, specific in that they're coming. I think we've had it with Wisconsin though, where they may come down to us for a transplant. But otherwise, generally, we've seen it more now doing these COVID lung transplants.
I think it's just that extra level of complexity that patients end up facing. I think if anything, this talk has highlighted the various complexities you never expect post-transplant for drugs that have been around for a significant period of time, but to get adequate coverage for them really takes a lot of, once again, time and effort.
Okay, and I have a question for our third group, Brenda and Karen. So you discussed a Belatacept case. Do you have any advice or strategies of how you could avoid an inpatient admission for someone that needed to start Belatacept urgently?
Yeah, so I think I can take this one. So something that we're fortunate to have at NYU is a designated area that we call the treatment room on our transplant unit. That's actually an outpatient area. So we're actually able to bring patients in and bill insurance, order patient-specific medication, as we mentioned, and that can help to offset the need for an admission to get the medication. And we're actually able to bill, unlike if you administer it inpatient, you aren't able to bill specifically. It's kind of lumped in the DRG, as Brenda mentioned.
How is that staffed, Karen? Do you have like 24/7 nursing staffing or?
Yeah, so we always have a nurse there. It's not open on Sundays, but it's open on Saturdays. We'll have one designated nurse. And it's actually a shared space with our BMT and solid organ patients. So we'll bring in patients for, specific types of infusions that are necessary that, they can't navigate outpatient for some reason.
Great, thank you. Well, I think we're quickly approaching time for today's discussion. I definitely would like to thank our presenters and my co-moderator, Cindy, for just a very thoughtful discussion and presentation today. And we'd also like to thank AST for allowing us to discuss on this very important topic.
AST would like to thank our panelists and all of our attendees for today's session. Please remember to complete the evaluation survey. We will follow up offline if there is any questions that we did not have time for. I do think we covered all of them though. We will also be posting the recording to the TX Forum and the AppCop hubs. Thank you again and have a great rest of your day.